and more specifically hypovolemic shock as it relates to blood loss. So hopefully you had an opportunity to come prepared for class and review the assigned reading so you kind of have a better understanding going into this discussion. Before I do continue, I want to just ask that you mute your microphone and please refrain from making comments and asking questions. As I mentioned before, in the comment section while I'm speaking, it can be distracting to both myself and your colleagues. I will pause at certain times and ask if you have any questions, and of course at the end as well. And you can certainly always reach out to me via email. So we will be together for approximately 2 hours. During the first part of our discussion, I'll be reviewing the pathophysiology of hypovolemic shock, the causes, the risk factors, clinical signs and symptoms, nursing interventions, the diagnostics, the tests, the treatments, all used in hypovolemic shock. And remember, again, when we're talking about topics such as these, it's obviously very important that you have an understanding of what hypovolemic shock is. But even just as important, remember, we're focusing on what our nursing assessments are. So what are you identifying? What are your interventions? And remember, we've been talking a lot about prioritizing. What do we see? What do we do? And what do we do first? Okay, so that should kind of always be kind of going through your mind when you're learning about new topics. So after we go through those things I just talked about, we're then going to take a short break. And when you come back, we will watch a reenactment video of a postpartum patient experience hemorrhagic shock. Hopefully, based on the learning that you've done in the first part, you'll be able to recognize a lot of the interventions and the signs and symptoms. And then after that's done, it's going to be followed by a case study where hopefully you'll be able to test your knowledge as well. I'm sorry. I'm sorry. I thought that you were able to hear me this whole time. Okay. Can someone tell me at what point I cut off, or right from the beginning?
Right when you switched into the tissue perfusion slide, from then on, I don't think anybody heard you.
Oh, the concept of tissue perfusion?
Yeah, as soon as you flipped on this slide, that's the last we heard of you.
Interesting. Okay, thank you so much. So I will, and did you hear me tell you about tissue perfusion?
No.
Okay, thank you very much. Okay, so I'm gonna go back. Okay, so the concept of tissue perfusion. So again, tissue perfusion, the flow of blood through the body by which nutrients and oxygens are delivered to cells and waste products are removed as supported by the anatomical structures and related body functions. So obviously hypovolemia does fall under the concept of tissue perfusion. In hypovolemic shock, the flow of blood is inadequate, right? So this causes poor tissue perfusion. And therefore, if there's poor tissue perfusion, there's going to be inadequate supply of oxygen and nutrients to the bodies and cells. And that's obviously a big problem. Okay, so to start, I am going to review the pathophysiology of hypovolemic shock. But first, I just kind of want to do a quick review of the circulatory system. As you know from anatomy and physiology, the circulatory system is made up of the heart, the blood vessels, and the blood. And the blood vessels, of course, are going to be the arteries, the veins, the capillaries. The arteries take the blood away from the heart to your body tissues and organs, and the veins take the deoxygenated blood back to the heart. And of course, you have the capillaries, right? Very important. They're the small blood vessels that connect the arteries and veins, and that's where all the exchange of gases and nutrients and waste occurs. Okay, so just a very quick review on that. Okay, so Hypovolemic shock. So hypovolemic shock, as you probably know from your reading, is caused by a decrease in the intravascular volume of 15% or more. Okay. So, which means that the amount of venous return from, which means the amount of venous returning from the heart decreases and the ventricle filling drops. And we'll talk a little bit about that. But as a result of this low perfusion, this low venous return, what's going to happen is your stroke volume is going to decrease, your cardiac output is going to decrease, and your blood pressure is going to decrease. And you probably, oh my, can you, can you not? Oh, okay. Sorry. Thank you. Okay. Everyone else can. Okay. Sorry. Okay. So thank you very much. All right. So again, so because of this low volume return, this low venous return to the heart, okay, the stroke volume is going to decrease, the cardiac and the blood pressure is going to decrease. So now you're talking basically about hypovolemic shock. So I'm not going to be testing you on the pathophysiology. So it's going to be a brief review. I know that you've taken anatomy and physiology, so I'm hoping that you're going to kind of make sense of what I'm saying. And if you have any clarifying questions, you can certainly ask, but I'm not going to be testing you on this material. If you just kind of focus on listening, I'm hoping that I can refresh your memory so that you can so that you can recognize that the manifestations of shock are basically a result from the body's attempt to maintain this perfusion. So the body's ability to try to maintain this perfusion, and the body's amazing at that, right? So it does all this work to try to get it stabilized. Okay, the symptoms that you're going to see are basically a result of this lack of perfusion. Sorry, I just need to take a sip of water. Okay. So this picture here is basically meant to be just like a simple depiction of the cardiovascular space. You have the heart, which delivers oxygen and nutrients to the organs and tissues. And between the heart and organs, you have the vascular space. So can you see my cursor on the actual screen? Anyone?
No.
Okay, thank you. All right. So, okay, so basically
Yes. Now we see it.
Thank you very much. So basically you have the heart and you have the oxygenated blood coming from the arteries from the heart into the body and the tissues. And then the deoxygenated blood is going to leave from the veins and it's going to bring it back to the heart into the ventricle. Okay. And it's going to fill up the ventricle, which you remember from going over the flow of the heart. So in the ventricle, you've got that preload. Okay. Sorry. And the preload is going to be before the heart contracts. So, and that's going to be low volume. So if there's a low volume, so if there's a low return, if there's a low volume return, so if there's a low blood volume returning to the heart, that means that there's going to be a low preload, and that's important. Okay, so I have this screen up here. Okay, that's going to kind of bring us through it again. All right. So ultimately, this decrease in the preload, okay, causes a decrease in the cardiac output. And that's important, remember, because the cardiac output is the amount of blood the heart pumps in 1 minute. So on average, roughly, an adult average person might put out about 5 liters per minute. So there's a decrease in the venous return. Therefore, there's a decrease in the preload. And if there's a decrease in the preload, it directly affects the cardiac output. And remember, the cardiac output is what's perfusing our body. Okay. So, so if there's a decrease in the cardiac output, of course, that's when we're going to see. Of course, if there's a decrease in the cardiac output, there's going to be a decrease in the blood pressure. So that's the hypotension. So what's happening to the body here? Okay, so decreased venous return, preload, cardiac output, hypotension. So the body responds to this decrease in cardiac output, right? It's amazing. So the blood pressure drops. So the blood pressure drops, and when the blood pressure drops, what happens is someone needs to mute their microphone. When the blood pressure drops, the heart reacts by increasing the heart rate, right? It's trying very hard to kind of get the body perfused. In addition to that, once the cardiac output decreases and you have hypotension, Okay, the heart rate increases, and then the body also vasoconstricts. So the blood vessels vasoconstrict. And they do that because if you remember that picture that I showed you, when the blood vessels vasoconstrict, basically what they're trying to do is they're trying to improve the preload. And remember, the venous return is low, so the preload is low. So by vasoconstricting, they're hoping that that they can increase the preload so that they can increase the stroke volume. So when this happens, however, okay, so when this vasoconstriction diverts the blood away, when this vasoconstriction happens, it basically will divert the blood away from the less essential organs. So like the GI, the GU, the skin, and it kind of tries to direct the blood flow to the more essential organs like the brain and the heart. So if you think about vasoconstriction and you think about what I'm telling you, which is that the heart has kind of kicked in, raised the heart rate, the body is vasoconstricted to kind of preserve the heart and brains. The signs and symptoms that are coming from the cardiac shock is going to be tachycardia, and then if it's pulling the perfusion away from the GI, the GU, and the skin, you're going to have pale skin, you're going to have clammy skin, you're going to have dry skin. Okay, so these are signs and symptoms. There's somebody that has their microphone on. Please try to everyone check their microphone. Thank you. So basically, the recap on this, okay, and I'm going to review it again in the next slides. Okay, I know I'm kind of going through this really quickly, but it's because I put it on the slides for you as well, and I just kind of want you to have a visual. So basically, you have low venous return, right? There's not enough volume in the system. That's going to decrease the preload, which is that ventricle filling. The preload directly affects the stroke volume, and the stroke volume directly affects the cardiac output. Okay. Remember, the most important thing about the cardiac output is that this is what is perfusing our body. This is what is giving our body the oxygen and nutrients that it needs. So it's obviously very important. When the cardiac output goes down, we become hypotensive. Our body is extremely amazing because I think if you remember from anatomy and physiology, it might sound a little bit familiar. We have that sympathetic response, and we have something called baroreceptors that basically can detect that lack of stretch in the heart. And when that happens, that's when the body vasoconstricts. That when it vasoconstricts our blood vessels. When it vasoconstricts our blood vessels, that's shunting the blood to the brain and the heart, and it's leaving the skin, the GI, and the GU to the side. The side effect of that is going to be clammy skin, pale skin, dry mouth. Okay, so now if the body does not respond, if the body does all that work and it doesn't respond, the tissue perfusion is going to continue, okay, and you're going to have tissue hypoxia, right? And then if that happens, you're going to starting having organ dysfunction, and then of course multi-organ dysfunction. So the body does its best to try to make up for it. Then it's our job to make up for it. But if it's not working, ultimately we're going to have organ dysfunction. Any questions about anything that I just said? I am going to go over on the next two slides as well. Okay, but I feel like it's important that if you kind of have a general understanding with this, I honestly feel that you'll just kind of basically recognize these signs and symptoms on your own.
I have a quick question.
Sure.
Twice you said the skin can be dry and clammy. Is that true?
Yeah,
both?
it can be. So just because of the stages of shock, and we're going to go through that again, and depending on the type of shock, it can initially become clammy or dry or vice versa. But those are signs and symptoms of dysfunction in the body. But it really kind of also just kind of depends on when which stage of shock you're in. And we're going to go over those. There's like 4 stages of shock. But thank you for the question.
All right. Thank you.
You're welcome. Any other questions? Again, we're going to go over this. You're going to hear this repeatedly. I think by the end, you'll be able to kind of speak comfortably on this. I'm just going to take a sip of water. Give me 1 second.
Do we have to know like the hormones involved in the process?
I'm sorry?
Do we have to know like all the hormones that are in the process for each like thing that happens? Like, do we have to know about the hypothalamus and the ADH and all that other stuff? And
100% not.
Okay.
100% not. And I'll answer questions specifically. And I know it's important to you, and I know your time is valuable. And I believe me, I want you to focus on what's most important. And that is not what is most important. So you will leave here knowing exactly what is important. And if I don't talk about it, it's not important. So just keep in mind, okay, you've taken anatomy and physiology to get into this class. It is important. As nurses, you certainly have to have an understanding of the body. We're reviewing that, and we're going to go forward with the slides, and we'll recap on that on the end. Okay. So hypovolemic shock. So basically, this is just going to be another review of what we just kind of talked about. So I told you that hypovolemic shock is caused by a decrease in the intravascular space of 15% or more. As shock continues, that percentage is going to increase. The amount of venous return decreases, the ventricle filling drops. We talked about the preload. And as a result, the stroke volume, the cardiac output, and the blood pressure decrease. Okay. The manifestations, which are the clinical signs and symptoms, result directly from the decrease in circulating blood volume. And we talked about that. So if your body is not getting perfused, okay, your heart is going to kick into gear to try to save you, and it's going to cause tachycardia. That's like one of the cardinal symptoms of shock. Okay, then you're going to have that pale skin, dry skin. In hemorrhagic shock, it's going to, you're going to have that cool extremities. The loss of circulating volume reduces the cardiac output by decreasing the venous return to the heart. We've talked about that. And as a result, the blood pressure drops, and the body induces the sympathetic responses. And I mentioned that, the baroreceptors, okay? So basically, it identifies the lack of stretch in the cardiac heart, and it immediately constricts the blood vessels, okay? So you kind of see where we're going there. Okay, so if the fluid volume is less than 500, and again, when we go through the different stages of the shock, you'll see it kind of, what the response is at 500, what the response is at 1,000. So if the fluid volume is less than 500, the sympathetic response is generally adequate. The body can usually correct itself and maintain it. With the sustained loss of 1,000, the shock stage progresses. Okay, so we need to immediately, we need to take care of that. The heart rate and the vasoconstriction increase. The heart rate and vasoconstriction increase, and the blood flow to the skin, the skeletal muscles, the kidneys, and the abdominal organs decrease. Okay, so we've repeated that several times. The amount of blood flowing to the cells eventually is too low to oxygenate them and sustain production of cellular energy. That's obviously an emergency. And if untreated, shock causes multiple organ failure. If you could just hold your questions and comments to the end, I will definitely answer that question. Please write that down. So we're going to talk a little bit about the mean arterial pressure. So basically, the MAP is the measurement that explains the average blood pressure a person's blood vessels during a single cardiac cycle, so a single heartbeat. So it's significant because it measures the pressure necessary for adequate perfusion of the organs of the body. So this is important for us to know what the MAP is. If you're on a vital machine at work and it takes that information and puts it right to the computer will actually show you what the MAP is. But I also feel like it's really important that you know how to calculate the MAP. Okay, so shock is triggered by a drop in the mean arterial pressure. MAP is the measurement that explains the average blood pressure in a person's blood vessel. So they feel like this is the more accurate way. The mean arterial pressure is significant because it measures the pressure necessary for adequate perfusion. Again, this is all about perfusion. So the normal MAP will be between 70 and 100. So that's why that number is important. So if you see anything less than 70, you know that the body is not being perfused as well as it should be. Okay, so that's the big takeaway about this. Okay, is that it measures the average blood pressure. Okay, and that you want it to be between 70 and 100. And if it's below 70, you know that the body is not being adequately perfused. All right, and this is a calculation. To calculate a mean arterial pressure, you have to double the diastolic pressure and add the sum to the systolic pressure and then divide by 3. So for example, if the patient's blood pressure is 83, the MAP would be 61. And here's the steps for the calculation. I hope you have a pen and paper because I'm actually going to have you do one. If I put it on this slide and I'm telling you it's important, it means I want to make sure that you know how to do this. So I want you to keep that in mind. All right. So take a minute and see if you can figure this out. So you're going to do this systolic blood pressure plus 2 times the diastolic blood pressure divided by 3. And then if we go to, oh, sorry, hold on. I think I gave you the answer. Sorry. So this one, so 74 over 50. So see if you can calculate the mean arterial. And I'll ask you to answer, but don't answer directly.
Can whoever called in please mute?
Yeah, somebody's called in on their cell phone and they need to mute their cell phone.
It sounds like they kind of just called in and maybe put their phone down. I'm thinking if they can't hear us asking them 100 times to please mute
I
themselves.
just saw caller 1 leave the session, so they might be trying to fix it and come back. I don't know.
Thank you. All right. So who wants to answer this question? Just raise your hand. All right, Stephanie.
So you take the systolic blood pressure 74. So it's 74 plus 2 times the diastolic, which is 50. So then you got 174 divided by 3, which is 58.
Which is what?
58.
Perfect. Excellent. Does everyone feel comfortable doing that and understands? So it's the mean arterial pressure. It's something that you should know how to do as a nurse. It'll be there for you electronically. But the most important thing I want you to recognize on this is that if you've seen a mean arterial pressure of 60 or below, that's significant, right? So when we talk about nursing and what's important and what I'm asking of you, I need you to identify the abnormal. And if you have a MAP of less than 60, that's abnormal. And then we're going to talk about what we want to do for it. But I would take note of this and make sure that you know how to do this. Okay. All right. So hold on. Sorry, I'm trying to lower people's hands. Causes of hypovolemic shock. Okay, so we've talked a lot about the pathophysiology. We've talked about the MAP. We've talked a little bit about the signs and symptoms, and we'll be talking about those a little bit more again. So again, hypovolemic shock occurs when you lose more than 15%. And of course, as that volume increases, the worse the shock is going to get. And there's different classes, which we're going to be going over soon. And obviously, if this happens, your body is going to be impaired. So 2 types of hypovolemic shock. We're going to be focusing on the hemorrhagic shock, but I want you to be aware that there's 2 types. There's the blood loss and there's the fluid loss. So blood loss is anything that can cause blood loss. It can be absolute trauma. It can be a visual trauma. It can be a stab wound, gunshot wound. If somebody's impaled, if somebody's in a car accident. But it also can be internal, right? So you have internal bleeding, and those are difficult because you don't necessarily know where that bleeding is coming from. And we're going to be talking about tests and diagnostics at the end. I know that you guys have done maternity, and we're going to be talking about a maternity case study later. But remember, it's not only important to know the causes of the hypovolemic shock, which is the blood loss or the fluid loss, but who's at risk, right? So young children, right, they're at risk when they have like these GI, and they're so when we'll switch over to fluid loss right now. If you're having excessive vomiting, or maybe our older people, excessive dehydration, sweating, diuresis. Both of these, both blood loss and fluid loss, cause a decrease in volume in our vascular system. Okay. So again, the same premise maintains for both of them. If there is a low volume in venous return, it's going to decrease that preload. So this is all about volume and tissue perfusion. And those are the two main key points that you just kind of need to take away this: low volume and low perfusion. So when it gets down to here, the conditions that predispose the patient to third spacing. So for example, liver disease, maybe somebody has, I don't know if you've seen anybody with like ascites, which is like a belly full of fluid. So you have albumin. Albumin is something that is a blood product that basically keeps fluid into our vascular space. So basically the consistency of albumin keeps fluid into our vascular space. But in liver disease, where albumin can be, if the liver's not functioning, if it's diseased and it's not functioning well, the albumin is going to decrease, and it's going to cause this fluid in the abdomen. So burns, right? There's no protective skin. The membranes are gone. So it's going to cause fluid out of that space. So again, the big thing is that it's blood loss and fluid loss. We're going to be focusing on the blood loss as far as the stages of shock, but really they're both extremely similar and they present the same as far as the symptoms, the tachycardia, and the paleness and this and that, because there's a decrease in the vascular space. Sorry, I just want to pause for a drink. Okay. So the next couple slides, we're going to be going down, and this was in your book too, so you can certainly review this. So class 1, so early hemorrhagic shock. So at this stage, you'd be losing less than 15% of your blood volume. I highlighted the percentage because I think that's important, which is about 750 milliliters. And remember, I told you we had about 5 liters in our system. So at this point, okay, this is where nursing assessment really comes in. At this point, they're really not showing any signs, but maybe they came in and they're a little bit of a risk factor. So the heart rate is still less than 100. Their blood pressure is within normal limits. Now, what's normal limits? But if it's on the low side of normal, like let's say it's 180, 108, or 100. The capillary refill is normal, less than 2 seconds. The respiratory rate is within normal limits. The urinary output is greater than 30. And remember, we're focusing on urinary output because remember when I talked to you about as the shock increases, it starts shunting blood away from those systems. So that's why maintaining those strict I's and O's and knowing what the body's doing is important. The mental status, the patient's alert and oriented, but they're a little anxious, okay? But their skin is cool and pale. So that kind of might be their first kind of symptom. The fluid replacement, crystalloid, we're gonna talk about that a little bit at the end. That's the normal saline and the lactated ringers. I just want to mention that that's kind of something that they usually give when the volume's low, but they're not into the later stages of shock. That might be the first go-to to kind of increase the volume in the body. So early stages, symptoms might be there. We're not really detecting them because they are falling under the within the normal range. Okay, so this is where we compensate. So hemorrhagic shock. So the blood volume lost in this stage is between 15 and 30%. Your heart rate and breathing might get a little faster. So now the patient's heart rate is 100 and 120. So now you're getting a little bit of tachycardic. The blood pressure, though, can still be normal. The capillary refill is normal. The respiratory rate is kind of increasing. So maybe 22 to 24 to 26. The urine output can be normal, but maybe it's slightly decreasing. And their mental status is alert and oriented. Maybe they're anxious, a little agitated. Skin's getting a little clammy. And again, at this stage, the fluid replacement would be crystalloid. I just want to pause here and ask, because it was interesting as I was going through these slides, because mental status, and we've talked about this rapport, what an indicator that can be. We've talked about that in cognition and delirium. And of course, now we're talking about tissue perfusion. So the brain perhaps is not getting perfused as well. So their mental status might be changing, but it's their behavior as well. So can anyone tell me if they saw a patient that was anxious or restless? How would you describe, what's your definition of restless? Can anyone give me an example? Anyone? You walk into a room and you say the patient's restless. And I say, what does that mean? Why do you think there's something
They
wrong?
can't get comfortable in the bed.
They can't get comfortable in the bed. So maybe fidgeting, again, just raise your hand instead of the comments. They can't get, so maybe fidgeting in the bed. Okay, good. Anyone else want to raise their hand and let me know? Restlessness.
They just look really weak. They're not moving as much. Their head could just be they just want to lay down.
So a change in behavior. Okay, so maybe a change in behavior. I mention this because I think it's really important to know that signs and symptoms of shock or anything that's going on with your patient is really it can be very subtle. So for example, if you have a patient all morning and they're fine, let's say they came in with a GI bleed and they they'd been there and they got a unit of blood the day before and they were laughing with you, talking, everything's great. And then you come in the next morning and they're just cranky. They're snapping at you, you're this and that. I mean, do you really walk out and be like, oh God, what a jerk? Or do you really kind of think to yourself, that's really kind of a change in his baseline. And that's very subtle, but very true. And it kind of, the other night I had a patient who came in and he basically came in, his H&H was low, it was 6 point something over 20. And the x-ray showed possible CHF exasperation, some possible pneumonia. Anyway, they sent him to the floor and on a new requirement of oxygen of 3 liters. So the reason I bring this up is because everything seemed to be okay. He's on this new requirement of oxygen. I'm just about to start the blood, but he kept kind of like making noises. He kept just like, just like groaning. And 3 times before I left the room, I said to him, "Are you in pain?" And each time he was like, "No." But there was something, it was just the way he was moving. He kept making noises. And I even said to him, "Do you often make noises like that?" And he said, "No." So for me, that was kind of an indicator, there's something going on. Everything seemed okay, but there was something going on. But long story short, he ended up being stepped up. He ended up being on a non-rebreather and dropping. But it's just an indicator to me that something, something was off. So it might be a very subtle early sign. So just something to pay attention to. So decompensated hemorrhagic shock. Okay, so this is not good. So at this stage, you're losing 30 to 40% of your blood volume, which is about 1,500 to 2,000 mLs. You experience a major drop in your blood pressure. So, you're looking at like 60 over 40 and begin to see changes in your mental status. The heart rate is very elevated. It's becoming more tachycardic. Oh my God, my voice is so dry. The blood pressure is obviously very decreased. The capillary refill is greater than 3 seconds because your body's not perfusing. They're obviously very tachypnic. This person is in visual distress. The urine output is basically non-existent. The patient's becoming very confused, very anxious, probably pulling at lines at this point. And again, the skin very cool and very, very pale. At this point, especially because you know that this patient has come in because of blood loss, now you're thinking of replacing that blood immediately. So you're thinking of the crystalloids, which is the normal saline and the lactated ringers. And of course, you want to replace the blood that the patient's actually losing. I just want to pause here and ask you, we've talked for a few minutes. If I tell you that a patient comes in with hemorrhagic shock, as a nurse, there's a lot of interventions, we'll talk about it. But if a patient comes in and they're bleeding with hemorrhagic shock, what are your two priorities? What are your 2 things that you want to deal with right away? Samantha, go ahead.
Stop the blood loss.
I was breathing.
Blood wall. Yeah, bleeding. Yeah, so absolutely. So stop the blood loss, 100%. That's like the first priority. Patients comes in with bleeding, we gotta stop. We gotta stop the blood. Where is it coming from? That's the thing. And then the second thing I would say is, especially if they're down in the shock, even early stages, you want to replete them, right? So you want to stop the bleeding and you want to replete the fluids. You want to increase that vascular space. So good. So that's important. So that's the focus. And somebody had mentioned ABCs. Absolutely. Always when somebody comes in, the priority is airway, breathing, circulation. But once that's established, the priority for someone that's coming in with shock is going to be stop the bleeding, and we need to resuscitate that vascular space, because if we don't, tissues are going to die, right? We need to make sure that our body is being perfused adequately. So refractory hemorrhagic shock is the last stage. So once you've experienced blood volume loss of more than 40%, which is greater than 2,000 mLs, your condition becomes extremely critical. It's almost past that. The heart rate is out of control. It's greater than 140. Your blood pressure continues to drop. The capillary refill is greater than 3 seconds. You're much more tachypnic. You're not making any urine. At this point, you might have lost consciousness. You're blue. You can see the cyanosis. There's absolutely no tissue perfusion going on. You're going to see the blue in the nail beds and the cyanosis. And of course, we're going to continue with the crystalloid and blood. Does anyone have any questions about these stages of shock? I just want you to, and you could raise your hand if you do. The most important thing that you kind of need to know about this, and of course, I know you're going to review them for your exam. A big one that you notice that everything's getting worse, right? The respirations are getting worse, the tachypnea are getting worse, the blood pressure is continuing to go down, the perfusion's going to go down. So you certainly need to know what's going on, I would say, in each of the stages. But it can be very subtle, right? When you're actually on the floor, and it can be a little bit more subtle than that. So you kind of, you need to pay attention to that. Yes, Sandy, can I answer your question?
Yeah, I just wanted to know, like, at what point, if a patient is on stage 4, obviously, how long are they going to continue the treatment? Because I'm assuming that, if they're at stage 4, even though they continue all this treatment and the patient does survive, they're going to have like a huge deficit,
Yeah.
and
You're
change their
talking about
quality of
lack of
life. So,
perfusion to
like,
the
how
brain.
long? Huh?
Are you talking about the lack of perfusion to the brain and
Right.
to the organs? Yeah.
Right.
I mean,
So once they
the
call
thing is,
quits.
yeah.
Mhm.
I mean, you have to go until you have to go. If the patient's um if the patient's a full code, and this is the wishes of the family or the person that's there, I mean, they're going to do everything that they can to save. But you're right. If it gets to this stage, how much of the lack of perfusion, if the person does recover, are they going to, what's going to happen to them when they come back? What's their quality of life? I don't know the answer. It's a great question, but we go until we can't go anymore. That's what they're going to do, unless there's wishes otherwise. So good. Aaron, can I answer your question?
Yeah, I just had a quick question. When you say like replacing the fluid with blood, do you mean whole blood or can it be like anything?
So it depends on where you are. So you have packed blood cells, which is more of a concentration of blood. And initially, though, they will, like the early stage of shock, maybe they'll just give fluids. So, and we are gonna go over the different types of blood very soon. So it'll clarify a little bit better. I was not sure if I should put that on there so early, but um, the thing is that when somebody comes in initially, um, you you're gonna depending on what their blood pressure is, they're gonna give fluids first until the blood gets there. So the blood isn't like magically sitting at the bedside. So if you can't get a type and screen, you're gonna give them universal donor blood. But until that blood gets to the bedside, you're gonna give fluids. So even if they're they're profusely bleeding, you're not gonna have it right there. So the first initial is always going to be probably the lactated ringers and the saline. Then you're going to, of course, order the packed red blood cells. And then while you're doing that, of course, and we're going to talk about this, you're going to order automatically there's going to be a type and screen for this patient, especially if they're hemorrhaging. And we're going to talk about the different types of products that are delivered to the patient in another few slides. And any other questions regarding any of that?
Thank you.
You're welcome. Oh, Stephanie, do you have a question?
Yes. How long does it take for like stage 1 or 2 where it's not so severe to incorporate all the organs to reverse it? So if you start giving fluids, is it that you see a difference in a half hour, an hour, or is it like a long
Well,
term?
yeah, it's a great question. And it really kind of depends on what's going on with the patient. So with some people, like I've had patients that that I've gone in and the blood pressure's been 62/40, and I give a quick 1000 bolus, and within that bolus it goes up to 80. So it depends on actually what's going on with the patient, like where's the bleed, how severe it is. So there's no direct number, but the hope is after that full bolus, you want to see it, when it goes from 60 to 40 and then it goes to 80, then you can kind of breathe and be like, okay, I know what I'm doing is actually correcting it. But as is the case, sometimes you give fluids and there's no response and it continues to go down. That's a whole other story. That's a whole other, what are we going to do now? So there's no definite answer for that. It really kind of depends on what the source of the shock is. I don't know if that makes sense.
Thank you.
You're welcome. Stephen, did you have a question? No? Okay. So nursing interventions. Okay. Logan, did you have a question?
Yeah, just a quick question regarding urine output. So, for example, we walk around producing maybe like 100 milliliters per hour. If
Correct.
if a like a healthy person, say for example, a 25-year-old male, he's walking around at 100 milliliters an hour, and say he gets shot, and he's in stage 2 or class 2 hemorrhagic shock. Will we see a urine output of only 20 to 30 milliliters about an hour?
I would say so, because if you're like that late in shock, remember the body's not perfusing the kidneys. And if the kidneys aren't perfusing, they're not going to produce. Does that make sense? That's why it gives you a sense of what of how bad the shock is. So if the kidneys aren't being perfused, they're not working. Just like if the abdomen and I think I come up upon it in a little bit longer. If the GI system isn't being perfused, the patient's at risk of kind of having like I want to say a bowel obstruction, but like an ileus, like a paralyzation of that organ because it's not being perfused. So if the kidneys aren't being perfused and the GI systems aren't being confused, they're not gonna work. All right. So nursing interventions and management, my favorite part, right? This is what you're here for. So you need to make sure that you know how to identify the signs and symptoms of shock. They can be very subtle: restlessness, paleness, early signs. You want to make sure, of course, you're going to be looking at your lab values as well. And we're going to be going over that at the end. So somebody had mentioned earlier, absolutely ensure the ABCs of the airway, the circulation, breathing. You're going to monitor their oxygen right away, their skin color, their breathing pattern, how their respiratory rate. These are all things that you need to identify and document. It is important that you identify it as soon as they come in and on any patient as your baseline. So that therefore, when you contact the covering provider, you can say respirations are, from going from 20 to 26. It might be subtle, but it's something. So that patient that I was talking about the earlier, he was like starting at 92% on 3 liters, but then all of a sudden he needed 4 liters, and all of a sudden I'm putting on a non-rebreather. So I was able to document each step of the way. How subtle over a 4-hour period, but because of the pattern documented and assessed, we were able to kind of get him help sooner. Place 2 large bore IVs. So obviously we spoke a few minutes ago about what the priorities were, and it was going to be to stop the bleed and resuscitate. If you do not have IVs, you cannot resuscitate that patient. As soon as they come in, you need to place those. And as nurses on the unit, if you know somebody's on your unit and they came in with the GI bleed, for example, and even though their H&H might be stable now, you need to make sure that the first thing you do when you walk in is to make sure that those IVs are working. Because if an emergency situation and you need to access that, you need to make sure that that's working functionally. And part of the protocol is usually if somebody's there for blood, that they have to have 2 large bore IVs. It's usually in the order set. So position the patient flat or in Trendelenburg position with legs elevated approximately 20 degrees. Can anyone raise their hand and tell me why that's the position of choice? Aaron.
To allow the blood to get to the brain and the heart
Yeah.
easier.
Absolutely. It's all about blood flow. Everything that we're talking about is blood flow. So if the patient's sitting up, that venous return is going to make it a little bit harder. So this is just about gravity. So you immediately are going to drop that patient. You take a blood pressure. If I go into a room and I take a blood pressure and I see that it's 75 over whatever, 60, 52, I immediately drop the head of the bed and I retake the blood pressure. So it's all about positioning. And we've talked about that a number of times before. So assess and monitor temperature. Depending on the type of shock, you obviously always want to monitor what the temperature, it gives an indication of the body. And hypovolemic shock, the temperature's going to be lower. So you're going to be a little bit more concerned about hypothermia. So you want to make sure that you're obviously monitoring that. It just gives an indication of what's going through the body. And of course, assess and monitor mental status and level of consciousness. That's a very big indicator. If they become more restless, more confused, that perhaps the oxygen is not perfusing well enough to their brain. So nursing interventions and management continue. So of course, you're going to be assessing and monitoring the cardiovascular function, the blood pressure, heart rate, pulse, peripheral pulses. Peripheral pulses are important, right? So if they're weak and they're 1+ or they're normal 2+, 3+, 4+, if they're bounding, you want to know what those peripheral pulses are. Or if you don't feel them, if it gets to such a point where there is no peripheral pulses, or they're very, very weak that you can't feel them. Monitor results of lab values. We're going to talk about the lab values at the end. For the most part, I want you to know that the lab values are important. Obviously, this is going to give you an indication of what's going on in the body, perhaps that you can't see. It's going to tell you what the H&H is, the oxygen carrying capacity of the body. It's going to tell you if there's like a lactic acid buildup. It's going to tell you, if there's electrolytes imbalances. So it's very important. Obviously, we need to know the lab values. Monitor urine output. We've spoken about that. Monitor bowel signs. That periodic ileus may occur, which I talked about, because there's lack of perfusion to the abdomen. And then, of course, there's, and when I'm talking here, it sounds like it's all emergent, but sometimes this is not emergent. Somebody's, like I said, in that early stage. So, you kind of want to create a calm and quiet environment to the patient. Of course, you always want to educate them. You always want to be with them. You want to explain to them what's going on. It's very scary to them. And then, of course, we've talked about it. You and I have done family dynamics together. Remember, it's not just patient family care. It's family-centered care, and you want to involve the family in the discussion and the plan of care, and certainly educate them about what's going on. This is just a picture of the Trendelenburg position that we talked about. You might want to elevate the legs as well to kind of promote the perfusion. So there's a lot of things that we can do, as nurses until we get the blood or whatever else we might need. All right, I'm just going to pause here for a minute, if you don't mind. I just need to take a little bit more water. Okay, so nursing interventions and management. So administer fluid. So fluid should be given as soon and as fast as possible. We've talked about that a few times, to restore the circulating blood volume. Remember, hypovolemic shock, it's all about that blood volume. If shock is caused by hemorrhage, infusion of blood and blood products may be indicated. So when we're talking about hemorrhagic shock initially, again, you might be giving the lactated ringers until the blood gets there. But if it's a great blood loss and the H&H is coming back and it's extremely low, they're going to go to these the blood and blood products. These are just a list of what the blood and blood products of the packed red blood cells. Basically, those are going to be the go-to because they've got the oxygen carrying capacity. So those are going to really get the oxygen moving in the body. The platelet concentrate, I think, those is going to help if the patient's bleeding. So platelets are going to help stop bleeding, coagulation. Fresh frozen plasma cells, that's basically a volume expander. And this one, I've been reading a lot about this, cryoprecipitate, I think, and that they give that to prevent or control bleeding. I guess it helps with clotting. So the colloid, I give this, I've never given it in an emergency situation. So remember I told you earlier that albumin has the ability to kind of keep things in the vascular space. So there's 5% and 25%. It's very thick. It's like this very yellowy, thick fluid. And it actually has to go, you have to hang it with a special tubing, which actually has a vent on it. So you actually pop open this little vent. So it allows the priming to go down. In this head of starch, I've never used this, but again, these are all used as kind of volume expanders. The interesting thing actually that I had read about the colloids was that you really need to monitor the PTT and the INR because apparently they can reduce platelet adhesiveness. So it's when you give it, it can be associated with the reduction of blood coagulation. So I thought that was kind of interesting. And then the crystalloid is the normal saline and the lactated ringers. Those are the two that you're going to be giving the most. Why they give one or the other, I think it's pretty subtle. Obviously the normal saline has the salt and the water, and the lactated ringers has the sodium and calcium in it. I think they give the lactated ringers more for patients with burns and probably blood loss. So those are the different types of management. I think for you, what you really kind of need to know is, and I put it in the classes, is that initially we're going to go with the normal saline and lactated ringers. But if the patient has profuse blood loss, we're going to go straight to the blood products. I think that's probably your bigger takeaway there. This I struggled with a little bit because I did a lot of reading, looking up, vasoconstrictors or vasopressors. And in hemorrhagic shock, it seems like there's a lot of debate on whether or not to give anything like this. So one of the research articles I had read, it said, only give this after adequate blood volume's been restored, because it can worsen the outcomes. And then another one that I read said, if you're going to give it at all, give it early. So, I wanted you to be aware of this because it's in your pharmacology book. But again, I think there's just some reluctance possibly to give this for any kind of hemorrhagic shock. I'm sure it's more useful in maybe cardiogenic shock or other shocks. The thing I would probably just kind of want you to know about this, and I highlighted it, is that it's a vesicant drug. So when you hang something that is a vesicant drug and kind of drug can burn the site, make sure that you're assessing and flushing that IV site first to make sure that's not. You should always know the contraindications in a drug before you give to a patient. So if the patient has a tumor or ventricular fibrillation, also extremely important, especially with these types of drugs, you want to make sure that you give the drug as prescribed. So this drug is given as a continuous infusion therapy only. This is not like I'm going to take it and push it in. So I think it's like a 250 and 500 ml bag. All right, but I just kind of want to mention this too because I just feel like it's a little controversial, but I'm not going to ask you about that. All right, so diagnostic tests. Again, we talked a little bit about this, the hemoglobin and hematocrit. It's important to know what the oxygen status and the carrying capacity is. Arterial blood gases. You guys have just done this on a test. So obviously those are important. It gives you an indication. So if there's an acid buildup in the body, so metabolic acidosis, if the kidneys aren't functioning or the patient's extremely hypoxemic, it's important to know what's their O2 carrying ability. So sometimes it might look like the patient's O2 is okay. And then you read the blood glasses and you realize, no, they're not. So making sure that the covering provider is certainly going to want to know what the ABGs are. BUN and creatinine, this is all about kidney function, right? So this is just kind of testing your kidney function. Same thing with urine. Blood cultures, this is to test infection. Of course, white blood cells, cardiac enzymes, what damage is going on to the heart. All right, so these are all automatic things that will go in with anyone that's in any type of shock, to be honest with you. So access. So we talked about it's important to have the 2 large bore IVs, but if the patient is really declining and we know that this is going in a bad direction, you might want to bring a central venous catheter, which is a large bore. It goes up in the superior vena cava, and you can give larger amounts of IV fluids through that. Obviously, if the patient comes in and you don't know where the bleed is, you've got the CT scan. endoscopic, the echocardiogram. This gastric tonometry, I guess it measures the amount of CO2 in the stomach, which I actually had not heard of before. So I thought that was interesting. So just kind of measuring, what's going on with the body. We're going to pause in a few minutes. I know I've gone over a lot. I'm going to review it again when you come back. What I'd like to do is we've learned a lot in this little bit of time about the causes of shock, why the signs and symptoms as the shock progresses. So when we come back, I'm going to show a video, and what I'd like you to do while you're watching the video is I'd like you to identify the signs and symptoms of shock as you're watching it, and see if you can do that. And I'd also like you to really pay attention to what the nurses are doing, the nursing interventions, and what type of interventions are being being given to the patients. And I feel like you have a pretty good idea already. And then after that, we're going to come back and test. We're going to review a case study, which has a number of questions that's going to test your knowledge as well. So before I let you go for like a 10-minute break, we'll come back at 10:40. Is there any questions on anything that we talked about so far?
Yeah, I was thinking about when you said the kidney's output, so like the urine output is going low. Is that not only because the kidney has poor perfusion, and like, because I read somewhere that it was saying like the urine out, like in an attempt to increase cardiac output, the body's gonna be holding on to fluid.
That's true as well.
Okay.
Yep, absolutely. That's a good point. Sometimes it tries to hold on to the sodium that it has. Yep, absolutely. Logan.
Yeah, one of the
he said-
slides, it says that during hemorrhagic shock, the vessels to the skeletal muscles will vasoconstrict. In the book, under class 2 compensatory shock, it says that they will vasodilate to the skeletal muscles. I was just wondering which one.
And in that vasodilation, is that under hemorrhagic shock, or is that under a different type of shock?
I think it's just like the compensated shock. It might just be like overall shock in general.
I believe that might be overall shock.
Okay.
There is a specific because again, there's different types of shock. There's 4 main types of shock, and you guys are going to learn about them as you go forward. They all have to do with blood flow and tissue perfusion, but they definitely can present differently. So I will check and get back to you, but I believe you're absolutely right. In the book, there is a general class in shock, but I also believe that there is a hemorrhagic different classes of shock, but I will check that as well. So, and you're saying in the book it says vasodilates?
Yeah, to the skeletal muscles due to I guess epinephrine, it will vasodilate to the muscles like a fight or flight
we're not
response.
giving we're not giving that epinephrine. My guess is that is in a different. I'll try to find the book where you're going away and clarify that. So,
Yep, page
and what's
1308.
1308? Okay, perfect.
And it
I
means
will
like
check.
epinephrine, like from like your adrenal,
Yeah. Oh, I see what you're saying. It's
endogenous, not exogenous.
That it's vaso. Okay, I will take a look at that. I will take a look at that. I think. Oh, well, I'll take a look at that. I think it's different with hemorrhagic shock, but I could have misread that, but I'm pretty sure. Aaron, but thank you very much, and I'm going to check on that on our break. Aaron, can I help you? Yep.
Yeah, so when we were going over like the causes and who's at risk, I mean surgery patients would be at risk for into hypovolemic shock, right?
Yes.
So
Yep. Anytime
do
of surgery.
they automatically just get fluids, or is it like case by case basis on like what they're doing like surgically to determine like what kind of fluids they're getting, or blood or whatever?
So usually everyone that goes into you never know, right? Anything can happen, the simplest of surgery. So they usually have fluids, whether they're running right then or not. I'm sure that they're there depending on what's going on with the patient. So that answer is just going to be very specific to what's going on with the patient. But yeah, if you're going into surgery, depending on what it is, especially, and you're going to be at risk for a number of things. So you're going to have that type, all that things we talked about. You're going to have that type and screen ready. You're going to have your large bore IVs. You're going to have fluids on standby for sure. Was that Aaron? Did I answer your question? Lillian, can I answer your question? Yep.
Yeah, I had a question about the map. So it said that 70 to 100 is normal, but then you mentioned it's abnormal if it's 60 and below. So I just want to clarify, like, let's say a patient's map is 65, I would still consider that abnormal, right?
Yeah, so it says that the normal range is between 70 and 100. So 65 is not awful, but as it starts getting dropping, once it starts dropping, you're going to start kind of like trending that. So 70 and 100 is normal, and then anything below that, it's affecting tissue perfusion.
Okay, and then the last thing is just, I know we were just talking about the vasoconstriction. When the vasoconstricts, it kind of throws me off because I always think of when there's vasoconstrict going on, that the blood pressure increases. So I could see that kind of like confusing me.
So that's the goal. So when those baroreceptors recognize the fact that there's that lack of stretch and there's that decrease in blood pressure, your body automatically tries to vasoconstrict those blood vessels. Just like the heart immediately starts pumping faster to try to get the blood out faster, though the body tries to vasoconstrict, you're absolutely right, to increase the venous return, to increase the preload, to increase the cardiac output. They're trying, and the hope is to kind of get the blood pressure up. But remember, if it's vasoconstricting automatically by itself, that means that the blood pressure's already low enough that it's not going to like vasoconstrict and like set you into hypertension. Does that make sense?
Oh yeah, it makes sense. Thank you.
You're welcome. Stephen. You have a question, Stephen? Nope. All right, so 10:32, so I'll meet you back here at like 10:42, and we only have till 11:30, so I kind of want to jump into that, and I will follow up with that, the vasoconstriction question. Oh, what page did you say that was on again? 1308? 1308. Okay, perfect.
I'm sorry,
Okay.
I had a little technical difficulty.
That's okay.
Could you elaborate a little bit on hypovolemic shock in terms of the hematocrit and hemoglobin? Sometimes it states that the norms can be higher or lower. Could you just delve into that a little bit more?
Well, sometimes, so the H&H kind of gives you an indication of the oxygen capacity. So the hemoglobin, basically tells you the delivery of oxygen, and the hematocrit is like the percentage. So if you have, for example, anything that comes into the hospital that is 7% or lower automatically gets transfused. So it basically is telling you what the oxygen capacity is of those red blood cells. So and don't forget, those red blood cells are bringing oxygen to the body. So it's important that we replete the blood with the red blood cells, those packed red blood cells, so that we can get oxygenation to the body as quick as we can. Water's not necessarily going to do that. Sometimes, and I don't know if you're referring to that, in dehydration, it could seem like it's a little higher. But in regards to hemorrhagic shock, or if we give too many fluids, maybe we dilute it. But for the sake of this hemorrhagic shock, you want to make sure that we're repleting those packed red blood cells, because those are oxygen carrying. And anything under 7%, you're definitely going to transfuse. Kara.
I think it was intravascular. So that's in terms of dehydration, in terms of intravascular.
Ask the question again.
So with intravascular, the norm's going to be a little higher. Is that?
No, it doesn't depend on the intravascular, but sometimes if you can give fluids, it can dilute it. But for the case of hemorrhagic shock, if you're losing blood, it's going to be low. It's going to be below 7. If you're bleeding, you're losing blood, it's going to show in the H&H. It's going to show your hematocrit below 7.
So that's what the book says in terms of the hemorrhagic, but in terms of intravascular, it says it's going to increase more than the norm. And is that because of dehydration?
I have to, because I don't know can you just tell me the page? Because I don't think I'm understanding the question
Yeah,
either.
it's page 1313 on the right side,
Okay.
about a third.
Thank you. I'm just going to read that because I feel like I'm misunderstanding your question, but I appreciate that, and I will. And who is this? Tell me your name again.
Steve.
Steve.
And
Okay.
it's,
I just want to make
Dr.
sure, because just in case I run out of time, I want to make sure that I get
Yeah,
back to you. And I appreciate I appreciate all of you actually reading the material and coming prepared. So it's good. I really want to I want to make sure that I get to this the case study because I think it ties everything up for you and kind of gives you a vision. And we are over at 11:30. Is there any other last question I can answer before I give you a little bit of a break?
I just want
Tara?
to clarify something really quick about the pathophysiology. You said when blood pressure decreases, the heart rate increases, which causes the
Yeah.
blood vessels to vasoconstrict, which is trying to improve the preload.
No. So the heart rate doesn't cause the blood vessels to. The heart doesn't cause. Let me see if I can go back to the slide. The heart rate doesn't cause the. The heart rate doesn't cause the blood vessels to constrict. What happens is when the cardiac output drops, the heart, to try to make up for that lack of perfusion, automatically starts beating faster because it's thinking to itself, I need to work harder to kind of get blood to my body. That's the heart.
Okay.
The vasoconstriction that I'm talking about is there's baroreceptors. The sympathetic nervous system gets, I believe it's the sympathetic, it gets notified basically, and these baroreceptors are measuring the lack of God, what's the word I'm looking for? Not contraction, expansion in the heart. So when that happens, it kind of is a signal to the body. These baroreceptors, it's like a signal. So when the body gets that signal that there's not enough cardiac output, it vasoconstricts the vessels in order to increase the preload. That preload, remember, the venous return is low, and then because the venous return is low, the preload is low. So when the baroreceptors are signaled, it vasoconstricts those vessels to increase the venous return. So that therefore it increases the preload and therefore it increases the cardiac output.
Okay.
Does that make sense?
Yeah.
Yeah. I know it's good to have. I really do kind of want you to have an understanding about it because I feel like it just kind of makes it simpler for you to understand that if everything's dropping, if your cardiac output, your preload, everything's dropping, your body's doing its best to kind of make up for that. And they do that by increasing the heart rate to increase the rate of blood going out. And they do that by vasoconstricting the space so that the preload increases.
Okay. Thank you.
Yeah. You're welcome. You're welcome. All right. So 10:45, and I'll meet you back here, and we'll get on the video. These are great questions, by the way, and certainly feel free to follow up via email if I don't answer your questions, and I will take a look at that page, Stephen, and get back to you as well. All right. So 10:45. So you guys can hear me correctly? Is that okay? You can hear me okay? So what I want to do, perfect, thank you. So I want to do is I'm going to share, I want to share a video. Those of you that are have access to my phone number, my clinical, please let me know if I start playing it and you don't see it. But I have to turn off my microphone, so I'm gonna have to stop talking to you. So I'm going to turn off my microphone. I'm gonna try to share the screen real quick. And and if there's an issue, someone can certainly text me. So I'm going to turn off my microphone.
Can you tell me what happened?
She just started bleeding all over the place. There's a lot of blood.
Can we get the doc in here?
We just had a baby.
How long ago did you have the baby?
2 weeks. 2 weeks.
We're gonna get in good care, but I'm gonna come around. Sir, are you her husband?
Yes.
Okay.
All right, so she's breathing pretty shallow.
Hey, Nicole, what's going
Put her
on?
on some oxygen.
Looks like postpartum hemorrhage, bleeding for a little while, real weak pulses.
Greg, you have an airway?
Yeah, airway's good. She's just breathing very shallow.
Okay.
Get her on the
We'll
monitor.
call
Get
RT.
pressure.
Get RT down here, please, and have them set up for intubation.
All right, pressure cycling, real weak radial. I've got it.
All right, we
carotid.
still have continued bleeding here.
All right, okay, pressure cycling, we're getting her on the monitor.
Great, let's get some IVs started. We need some emergency release blood.
Yep, super weak peripherals.
Greg, when you're done putting that
I'm gonna
ECG
get
on,
her
would you
line.
please listen to her breath sounds to ensure we have adequate respirations?
Yeah, I'll do her.
I have a line setting up life flow.
All right,
Where's
so I'll
the
touch
blood
at
at?
67 over 30. Map 44.
Week premature.
Weak premature.
Let's start off with a 500 ml bolus of normal saline, and when the blood gets here, we'll switch immediately to blood. Make sure we reassess
Fluids are
in between
infusing.
boluses, okay?
You're on
All right,
labs.
lung sounds are clear, just very shallow.
Great, we'll be prepared to assist
Labs
with
are
respirations if
drawn.
needed.
Send them off to
Yeah,
lab.
PD, I'm ready.
What's her name, sir?
Her name's Kristen.
Does she have any allergies?
No, she's totally healthy. We just had the baby and I don't know what's happening.
Hey, Kristen,
Never had
can you hear
surgery.
me?
Never had surgery.
Is that
no.
bolus
She
coming
has,
out okay?
She has placenta previa.
Hey, sir, I'm Dr. McDonald. I'm going to be taking care of your wife while she's here in our ER. We have an OBGYN on the way, okay? We're going to
Is she
take
gonna
care.
be okay?
She's going to be fine. I think we're going to get her in the right direction.
Whole
We want to
blood.
get her vital signs to a
Right,
more
you know,
normal
whole blood?
state, okay?
Pressure 67 over
Let's switch
30.
to that whole blood, please, right away.
Heart rate's down to 126. Little better radial pulse.
Good. I think we're headed in the right direction. Greg, reassess breath sounds for me, please.
I'll
Okay,
cycle another
thank
one.
you.
Here's that.
Lung is still clear.
Blood is infusing.
Cycling another pressure. Kristen, can you hear me?
Great. We'll put that blood in as fast as we can. We'll start a second unit, okay?
Kristen, can you hear me? You're in the ER. We're going to take good care of you.
Did we order a second unit?
Yeah, it's coming. Hold on.
Okay.
Thanks. Pressure cycling.
Our airway's
82
still
over
good, Greg. We
41.
still have good stats.
And heart rate is 113.
Got about 150 at the
That's
front
good.
end.
Yep.
All right, our cap refill still 4 seconds.
Kristen, can you hear me?
Is the second unit on the way?
Kristen, you're in the emergency department. We're
Yeah,
taking
second
good
unit's been
care of
ordered.
you.
Great. So do we have any labs back yet?
Let me go check for you. You get labs back?
Greg, please keep an eye on that airway. If we need to assist her, let me know, all right?
Here's the blood. All right, so blood. Second unit of MA.
Are we still waiting for this unit?
All right, I'm gonna cycle a pressure.
We'll do a quick reassessment between units of blood and get that hanging and
Cycle
going.
a pressure about every minute.
Yes,
Does that work?
please.
Okay. Stronger radial. So checking that lab.
What was our last blood pressure?
Cycling that last one was 82. 91 over 54.
So we're heading in the right direction. Heart rate's come down almost 20 points, so that's good.
Kristen.
Let's get that pressure cycling every 60 seconds, okay?
All right, sounds good.
Until we get her
Kristen.
pressure up.
Kristen, can you hear me?
Lung
Got a
sounds
mud.
are clear. She is breathing a little deeper.
91 over 53. Heart rate's down to 89. I've got a great
That's
radial
good.
pulse now.
Second unit
Sure,
of blood
these are
is
great
infusing.
signs that she's responding to our care,
You
okay?
be okay?
Right now, she's responding to our care. I'm going to let the OB
She's
address
opening
her.
her eyes.
Excellent.
She's
care.
responding.
Your husband's here with you. You're going to be okay.
Right here, Kristen.
You're going to be okay. You're in good hands.
So a cap refill is 3.5 seconds.
Responding a little more.
Okay.
91 over 53, map of 66.
Okay, I'll be right back to you in 1 second. Can you guys hear me?
Yes.
Okay, great. Thank you. I'm just going to get my slides back up and we'll talk about that.
Good video. Thank you.
You're very welcome. Well, that was really good, wasn't it? Really kind of hit everything we just talked about. So I'm hoping that, you know, you were able to pick up on that a little bit. So thoughts on that. So anyone want to kind of articulate, um, you know, things that they kind of noticed right away? Thoughts on that as you went through? Samantha?
I noticed that her vitals kind of started to go in the right direction pretty fastly after they started to infuse that blood rapidly like that.
Yeah. So I thought that was interesting. So it was good. It gave you right away. I think her initial blood pressure maybe was 70 over something. Her pulses, you know, were a little weak, and it seemed like as you said, as they perfused her, it started coming back quickly. Any other observations other than that? There's a lot. There's a lot there. So Lillian, go ahead.
Yeah, her heart rate started decreasing when her blood pressure started going up. I also wondered why didn't they like remove her pants to see if she was having any bleeding going on?
Well, again, so the priority when you talk about it is immediately, it is
Ew.
immediately to stop the bleeding, and they're going to suspect it, right? They're suspecting that there's a bleed,
Hmm.
but it's probably internal. They're not going to be able to get to it. So then the priority is going to be the resuscitation. Now, if the resuscitation didn't work, that's a whole other story. The pants comes
Okay.
off, they're assessing for bleeding, and she's going to the OR. But yeah, the priority right away was going to be that resuscitation.
And they obviously saw the blood pressure getting better, circulation was getting better, so that's why they didn't go any further.
Correct. And I'm sure they gave her that full assessment afterwards, but absolutely.
Okay.
Any other observations? Sandy. Sandy, did you have something to say?
Yeah, I just saw that all her symptoms were the same as what we had in our text. So she had like that unconsciousness, the shallow breath, the weak radial pulse, and then like as every intervention that they applied, they started to see like the interventions working, you know. So her apical started going up, her BP started going up, and then was slightly opening her eyes and all that. So
Yeah. So, and her level of consciousness. And you saw that that nurse was constantly reassessing that, constantly talking to her, telling her to open her eyes because she knows that that's an indicator that the patient's kind of coming around. Her pulse is right. I think they were weak, and that you could hear them saying, you know, that they were getting stronger. And then they were continually asking about the airway, correct? Like that's, you know, that was really important. Um, I don't know. Heidi, go ahead.
So I just kind of typed some notes as I was watching it.
Sure.
Immediately O2, constantly checking the airways. They had a call into RT for possible intubation, constantly checking the vitals. They immediately started the IV saline and switched to the blood as soon as it arrived.
Yep.
The MAP was 44. The nurse checked the name and allergies. The OBGYN was called. Um, again, checking the breath sounds. I was pretty impressed that you could infuse a whole unit of blood in under 2 minutes. And then they started the second one.
Yeah, I don't know what that machine is that that I don't know what that is. I've never seen that before, but that's a thing. That's the video was I think to try to you know, explain what the use of that is. But yeah, they ran that pretty quickly. And then you mentioned the map, right? And that was important, right? That's a really big deal. So I think the map initially was like 40, and then you know before she went, it was like 65, which again isn't 70, but it's definitely not 40.
Right.
So good.
And then at the
And
end,
go ahead.
yeah, it was just then at the end, the nurse told the husband that she had opened her eyes.
Absolutely. Absolutely. That's such a big deal, right? You need to keep the family. They're worried, they're there. You know, being a nurse, you just have to you know, it's that is an excellent depiction of what goes on. So to be able to have the presence of mind to constantly, because you're reassuring your patients too. You could hear her say to the patient all the time, I'm here, you're going to be okay. I'm here, you're going to be okay. And then turning to the family member, asking them some clarifying questions about any allergies, and then reassuring the family and giving them education. At the same time, you're checking labs, you're constantly updating the doctor. And this is why that S bar, that learning how to give quick, concise information, and why it's so important for us to learn as nurses, not only to prioritize our care, but to prioritize what we're saying. Like, what's the most important information that they need to know? How quickly can I give it to them? Anne, any other comments or follow up?
I just wanted to comment kind of at the pace that they were infusing the fluid and the blood. I wondered, there's no danger to that? Is fluid overload or?
Yeah, so great question. Excellent question. So yeah, this is always going to depend on what stage the patient's at. So for example, if they didn't have blood, right? Let's say they didn't have blood on that hand that quickly, and they started giving fluids. I think the ratio is 1-to-1. So every liter of blood you lose, or you get 1 liter of blood, but not 1 liter, but for every. But if you're giving like lactated ringers, you have to give 3 for every 1, I guess is what I'm saying. So let's say they didn't have the blood for whatever reason, and then they had to give her fluids, and they gave her a bag and nothing happened, and then they gave her 3 bags. So if that happens, we have to resuscitate. We certainly have to keep giving it because we need to increase that volume. But once you start giving that amount of fluid as a nurse, then what are you assessing for? Do you know? You just kind of said it.
Well, like fluid overload.
Yeah, fluid overload. So then you're listening to the lungs, you're listening to crackles, you're looking for edema. So depending on the type of shock and what you're giving it for, you're certainly going to be monitoring for fluid volume overload if you have to give. And it's one of those things. It's like, am I harming the patient? If I don't give anything, I'm harming the patient. So it's every situation is going to be different. But good question, Aaron.
Yeah, I just wanted to comment that I noticed like how fast they were moving, but they also like were asking the husband about her history when they started like implementing their interventions and everything, and he had mentioned that she had placenta previa with that pregnancy and she was 2 weeks postpartum.
Yeah. And very interesting information, right? So that's the information that you kind of want to know, like, why could this patient be bleeding? Like that's the information that you need to kind of, as a nurse, selectively get as quickly possible. Yeah, I thought they did an excellent job. And I thought it was an excellent depiction of the constant monitoring, the constant updating, and getting that vital information from the family member. Because if that family member wasn't there, we wouldn't have known that. Maybe we wouldn't know the source of the bleed. Stephen.
I thought it was great. I constantly saw the other nurse monitoring the lungs, sounds for clearness. But I also wonder if there's a question of legality in terms of consent. Was that because it's an emergency situation, or was the husband there? Was that a verbal consent?
The consent for the blood?
Right, consent for the blood.
Yeah.
Also, in the event that this patient did not want blood, would it have gone a different way? Or how
Yeah,
would
it
we
definitely would have. Yeah, I've been in that situation. So that's tough, right? So there's people that, maybe a certain religious groups do not want to have blood. That's their right. That's usually in their chart. That person comes in quickly and it's an emergency. You're going to resuscitate. They did start with the fluids, but yeah, they have to. If the patient's unconscious, you're obligated to do everything you can for that patient. The moment you get into the chart and it says, I do not want blood products, then that needs to stop, and that takes it in a different direction for sure. Good. All right. So excellent job. I thought you identified all of the right things. I feel that based on what we talked about today, I feel like you have a really good understanding. And remember that when you are going to be testing on this information, the priorities are for you to, identify the signs and symptoms and the nursing interventions. That's always going to be really, key, right? So what those nursing interventions are, identifying signs and symptoms, and then of course the priority. So if I give you a list of and I think it's in the case study too. If I give you a list of things to do for the patient, the question is going to be, what are you going to do first? And of course, we always know we're going to protect the airway first, if that's the option. Place IVs, resuscitate, put in Trendelenburg. There's going to be an order to those things. It's happening so fast. You guys will be doing it all simultaneously, but it's all about testing your critical thinking. I do want to kind of jump into this case study because we have just a limited amount of time, because I'm hoping to leave a little bit more time for questions, but you did a great job. I appreciate the feedback. Okay, so case study. I will read this, even though I know you can read this. So Mrs. Stewart is a 27-year-old female, presents to the emergency room 2 days postpartum. She's complaining of severe abdominal pain and reports some vaginal bleeding. She reports an uncomplicated pregnancy and a normal vaginal delivery. She and her husband both appear anxious. So based on that presentation, what initial nursing assessments need to be performed? So the patient came in. What initial nursing assessments would you perform? Someone wants to raise their hand. Logan.
You would do your ABCs, and then following that, probably get vital signs, or maybe part of the cardiac, the circulation. You would get your vital signs and such.
Absolutely. Vital signs, always, right? Anytime, anything, that's going to be the first thing that you're going to do, barring that airway right away. Anna, anything else?
Yeah, I would do labs like the H&H.
Yes. But remember, the question is, what's the initial nursing assessment? So the question is just like, the patient just came in, they basically presented, they said that they just had a baby, and now they've come to you, and you're just doing your initial assessment right then. So what's your assessment? What's your physical assessment? I guess I should clarify that. What's your physical assessment?
I would check her for vaginal bleeding and whether she had, how her fundus was doing, and making sure she wasn't hemorrhaging through her vagina.
Yeah. So yes, you are definitely going to assess all of those things. But the first assessment going in, you're going to take the full set of vitals. You're right there. You're going to listen to the lungs, her pulses, skin color, and absolutely, you're going to assess for a bleeding. You're going to assess, you said the fundus. You're going to see if there's any signs and symptoms of bleeding, knowing that she, was postpartum. So good. Let me just. All right. So hold on. I feel like I've missed our full set of vitals. Okay, so here we are. So now you've done that. You've done the vitals. You checked for bleeding. You've assessed her lung sounds, of course. Upon further assessment, she becomes pale and weak, and now her pulses are 1+ bilaterally. The clin-tech obtains vital signs and system to the bathroom, and that she notices that the sanitary pad is bright red blood, and these are her vital signs. Her blood pressure is still within normal limits, but her urine is dark and yellow. Okay, so maybe a little concentrated. Her heart rate is 92, which is in the normal limits, but it's a little bit on the high side. The respirations, a little bit on the high side. Temperature, 97.8. That could be her baseline. And her oxygen is okay. What do you believe is going on with her at this point? Anyone have a guess? Sandy.
She has an active bleed because she has that bright red blood.
Yep. She has got that vaginal bleed. And I think her delivery date was 2 days ago. And what is she showing signs and symptoms of? Anna.
Early hemorrhagic shock.
Early hemorrhagic shock, right? So we talk about that little bit of anxious. I mean, it's very subtle, but the reason why you would think that it might be early hemorrhagic shock is because she's 2 days postpartum, right? So you kind of have to put the whole picture together. So everything's a little bit of subtle, but she did just have the baby, and you're seeing active signs of bleeding. So good. So she's bleeding vaginally. She may have a tear or rupture in the uterus from her delivery 2 days ago. She's weak, and she's starting to show signs of shock because she's pale, right? That was one of the signs. And her pulses are weaker, right? They've actually become weaker. So what interventions would you do to take would you do for her at this point, and why? Megan.
Start an IV.
Absolutely. If you've realized right now the fact that she is in early signs of shock, you know that you're going to need access. So 2 large bore IVs. What else? Ryan, what else?
Lay the patient flat. Possibly in the Trendelenburg position, but I think it might be a little early to start going head down, legs up.
Yep.
But definitely lay her flat.
Perfect. Excellent. I love that answer. Excellent. So you come in, you notice the shock, blood pressure's low, pulses are low. You drop her in Trendelenburg position. You make sure she gets 2 large or IVs. And then what's the next step that you want to do? Lillian.
Vital signs. What the first thing?
Definitely vital signs. Yep, absolutely. And then who do we want to notify?
The provider.
The provider. Yep. So basically you've noted decline in your position, and you don't want to call the physician with nothing and be like, oh, their pulses are weak. You're always going to want to call the provider and give them the assessment. And of course, that's going to include vital signs. So you're going to drop the patient flat or in Trendelenburg. You're going to notify the provider, and you are going to start 2 large bore IVs. All
Real
right.
quick, is that the
Yeah.
order you would do it in specifically?
What order did I say? What order do you think? I don't have that slide up anymore.
You said, I believe it was position first, and then
Yep.
it was the IVs were last, is all I remember, and I thought we were.
What do you think?
First.
What do you think? If you walked in the room and that was the case, what would you do immediately?
Well, I think the easiest thing to do first would be the position.
Correct. You're correct. It's not that the IVs are not a priority. Of course they're priority, but you're going to drop the head of the bed, and then you're going to simultaneously notify the provider, and you're going to be grabbing stuff for the IVs. Absolutely. So
Okay.
you're correct. Yep. No problem. Oh, did I skip a question? Hold on. I'm sorry.
Yeah, I had a
What
quick
orders?
question. Is
Go ahead.
do you need or do not need a physician's order to start those IVs?
Oh, that's a really good question. No, I start IVs all the time. There is an order set for IVs, but no, you would start those IVs. You would not need an order to do that. You would definitely start those IVs. Just like if somebody, for example, you know how you get how oxygen is an order. If there's not an oxygen order, you're still going to put that oxygen on. You know what I mean? So having said that, what orders do you expect? So now this is the situation. So now you're the nurse, right? And we always try to kind of, not only do we prepare for the orders, but we advocate for them as well. So we don't kind of just like send something to the doctor and then wait for them to tell us to put the IVs in. And for example, if the patient urinated, I wouldn't toss the urine. I'd probably put it to the side, expecting him to ask me or advocating for that to be sent. So knowing that, and a lot of our job is advocating for what time is it? For patients, like that patient that I was referring to before, that guy that came to my floor, he came in with that shortness of breath and this and that. And I put Telly by the bedside before the order put in. I texted the doctor with the vital signs. And when I texted him, I said to him, do you want to order a chest x-ray and an ABG? So our role as nurses have really evolved. So that's why we really kind of need to be aware, and we need to kind of advocate. And I'd also advocated, do you want me to give a diuretic? Because there was a possibility of fluid volume overload. So we're definitely part of that process. So it's important to kind of know the treatments are. Absolutely. So okay, so what orders do you expect to receive from the provider based on this, Ryan?
Well, probably a full set of diagnostic testing.
Yep, absolutely.
Hemoglobin, hematocrit, ABGs, blood cultures, cardiac enzymes, things like that.
Yep. So let me see. Oh, hold on. Oh. Oh gosh, I'm so sorry, guys. Where are we? Yes, okay. So case study answer. Yep. So CBC, H&H, of course, the type and screen. He's gonna expect to give you fluids, and then possibly prepping for that central line and possibly surgery. So
I would have assumed that, I'm sorry, Professor, that
no,
within
no.
those first orders, we would have seen like an ultrasound or like a flat plate or something like to like hone in on what the actual, you know what I'm saying?
Yeah, absolutely. You mean where the blood is coming from?
Right.
Yeah. So again, they do know that it's postpartum. So yeah, you're absolutely right. Maybe they would have ordered an ultrasound or had the OBG team come look at the patient. So yeah, trying to find the source of bleed and where it is for sure. All right. So you notice Miss Stewart has already saturated another pad. So this is where it kind of gets interesting. So you're the nurse and you're by the bedside and you're seeing that this patient is declining in front of you. So you immediately notify the ED provider that you believe that she is decompensating. You receive the following orders: give 1,000 ml lactated ringers, administer oxygen, do a type and screen, transfuse 2 units, and give morphine for moderate pain. So which of these orders will you do first and why? Oops, sorry. I think I declined. Raise your hand again. I think I declined you guys by accident. Lillian, go ahead.
The first thing I'll do is give oxygen.
But what was her oxygen? I think her oxygen was okay, right?
Oh, I'm sorry. I thought it was less than 92.
That's okay. I think her oxygen was 94%. I could be wrong.
The first thing I'll do is the IV, the lactated ringers until the packed red blood cells get there.
Perfect. Excellent. Right? Because that goes right back to our priorities. We need to resuscitate, and it's going to take a little bit for the blood to get there. In the meantime, we'll get an emergency bag, but we'll do the type and screen. The morphine's not gonna it's not gonna help with her perfusion. It's just gonna help with her pain. So definitely the priority is going to be that. So there's no evidence of airway compromise. Always address the issue as soon as possible. You're checking, of course, the ABCs, and you're going to initiate that bolus. So Mrs. Stewart responds well to the first liter of fluids, but is still bleeding profusely. The obstetrics team arrives and tells you to obtain 2 units of emergency blood instead of waiting for a type and screen. You also receive orders to transfuse a 2nd liter of LR, which you have initiated. After examining the patient, the team determines that this patient may need to go to the OR, but they want to monitor her in the ICU first. The ED physician places an arterial line and a central line while you initiate the first 2 units of packed red blood cells. Mrs. Stewart's hemodynamic readings are blood pressure 90/58. Her MAP is 66, so it's still okay. Her heart rate is elevated. Her respirations are elevated, but she's now a 90% on room air. And you notice that she's extremely confused. She's getting confused and she's extremely pale. So she's starting to obviously get worse. So what should your immediate course of action be if you see that this happens? What is your immediate course of action? James.
I would say monitor her airway and because her oxygen decreased, you'd give her some oxygen.
You would definitely give her oxygen. And then after you gave her the oxygen, what would you do? If you know that she's declining further, the doctor just told you that he wanted to monitor her and send her to the ICU, and then he leaves. And now you notice that she's actually further declining. So you gave her the oxygen, and then what's the next step? Sandy.
You're gonna call the doctor and let them know that she's decompensating, she's not safe for transfer.
Absolutely. You're going to notify the team. You're going to advocate for your patient. And then, of course, you're going to continue to ensure that her airway is protected, like James said, and you're going to ensure that she's getting all that fluid and blood volume that she needs. Yep. So you call the team and tell them she needs to go to the OR now. So The team returns and agrees that Miss Stewart is too unstable to be transferred. They agree to take her to the OR right away. And in the OR, she's found to have a uterine wall tear, which is repaired successfully. She spent 1 night in the ICU and 2 nights recovering postpartum before being transferred home to her new baby. So what, if anything, would you have done differently in this situation? And maybe nothing. I mean, it seems like you notified, but does anyone have any thoughts on that, if they would have done anything differently? Sandy?
I saw that the IV accesses were done a little later on. It seemed like, and when we watched the video, they kind of got that started right away.
Yeah, the IVs, it would have been in immediately. Absolutely. That would have been your number one. You would have done that immediately. You would have checked the airway. That's all kind of simultaneous, but and that the top 3 things that you need, airway, but you need to get access for sure. I don't know. I think if it was me, I'm trying to think back, because I remember reading and thinking, I think when the team first left and said, oh, we want to monitor in the ICU, I was not feeling good about that when I was going through the case study myself. I would have probably advocated right away, like, no, there's something wrong. As nurses, we know, just like I had that patient the other night that I picked up, and he was restless and he was this, and there's just something, and, you just know. And I think I would have advocated for not being sent to the ICU, but being sent to the OR right away. And if they didn't listen, I think I would have called a rapid response to get people there. All right. Any other further questions or comments on that? Lillian, you have anything you want to add to that?
Oh, I don't have any questions. The only thing I was visualizing was like as soon as you get the IV site ready, I would automatically just do some labs, like put some labs in, just so I could determine more exactly what's going on.
Yeah, absolutely. Those are all the things that are kind of getting done immediately. So honestly, the soon as she gets there, this is all kind of happening simultaneously. So the doctor's going to put these orders, and if the phlebotomist doesn't come up, or I don't know, depending on the hospital, maybe you do them yourselves. You definitely would immediately send. You want to find out everything you can about this patient. You want to send the labs. You want to send a urine. You want to send well, I guess that's it, really. You want to take the vital signs. You want to constantly be assessing. You want to do the type and screen. You want to make sure that's done. You want to immediately see if she's got any allergies. Has she ever had any reaction to blood? Ryan, you have any questions?
Not really a question. I was hoping that perhaps we could get the full PowerPoint to use for studying purposes. The one that we have only has 25 slides, and so it's kind of missing this whole case study at the end. And I think that would be a big help for us.
Sure. I'd be happy to do so. I will place it on the, I guess, in your folder. But just so you know, when we're doing, when I'm teaching class, obviously I want it to be interactive, and I don't want to put this up with the answers either. But I want people to show up and kind of participate and get the worth of the full class. So sometimes there'll be things that I'll kind of be throwing in at the end, but I'm happy to share this with you. I do think that it does help, but this is more for conversation. But I'll be happy to put that up for you. But just so you know, it's you'll probably see that in the future. I try to like to kind of keep the case studies and the videos to myself prior to, so that you haven't already looked at it, read it, and digested it. I kind of want you to try to critically think.
I totally understand. I appreciate it.
Yeah, no problem, and I'm happy to post that for you. So it's 11:20, and who was it? Stephen that had that question about the vasoconstriction and the vasopressor.
Yes.
I did quickly read at it, and honestly, that's kind of like a tough paragraph, but I will say that I think, and again, it was very quick, and I think the general understanding that I thought I was reading was that, and I'm going to go back and look at it because again, it was quick look, was that it seemed to say that it was vasoconstricting, but the heart was dilating so that it would cause the heart to increase. I don't know. There seemed to be a difference between something.
I'm sorry.
The epinephrine being released so that the heart would contract faster, which is true, right? The body does do that. So the body does release something to make sure that that heart does contract how come I can't say that word? Contract
I think it was
faster.
someone else, but I understand what you're saying. Yeah, I think someone else asked that question.
Oh, sorry. Okay. Yeah. But I'll look into that. But I think that that's what the cardinal response to all shocks is that tachycardia. That's going to be like that first sign because that's your heart, trying to, to save you, basically. It's pretty amazing. Okay, so recap on this. You did a great job. I appreciate you coming prepared. I appreciate the feedback and the dialogue. So when you're preparing for the test, I would say that I'm always going to test you on your ability to recognize signs and symptoms. I'm always going to test you on your ability to place the nursing interventions. I'm certainly going to want you to be aware of, perhaps, what some of the diagnostics are, and, would you give blood over, maybe normal saline. And remember, though, the questions aren't always going to be like that straightforward. Like, we're testing your ability to prioritize, like what we talked about before, walking in the door. Do I drop the bed? Do I protect the airway? Do I push the IV? Do I put the IVs in first? Okay, so it's going to be your ability to prioritize, to recognize. I feel like you're going to be fine. I feel like you already seem to have a good understanding, but I'm certainly available for any follow-up questions. You can certainly email me. I haven't actually put the questions together yet, but I thought it was great dialogue, and and I appreciate your attention. Any other further comments or questions that I can help you with?
Would that be a test question in terms of the actual order? Would that be something you would list on the test? Is that something we would have to be concerned about, the actual order itself?
The actual order of what?
The actual order of, placing the IV, lowering the bed. Is that
No, not necessarily this year, actually, but that NJEX thing that you guys are going to be doing, they're going to be asking a little bit more of that, you guys putting things in order, which is probably a good thing. That is not something I'm going to ask. What I'll ask you is what is the first action? I asked a question before in one of my exams. What's your priority action? What's the priority? Obviously, airway would be one, and it depends on what your options are, right? So for example, that test question on the case study where it said, these are the orders, what would you do first? And you guys were like fluids, just like that. Very simple, nothing tricky. It's going to be very clear. It's not going to be a subtle, for example, knowing the stages of early shock versus late stages. I'm not going to necessarily give you maybe, what's the difference between 1 and 2. It'll be very clear cut. So you just need to make sure that what the stages are. Like I said, they're kind of subtle. Sometimes they're slipping into each other, but I'll make it clear what they are. So, you should know, tachycardia in early stages versus late stages. It should be over 40. So nothing, I just want you to honestly, genuinely know the material, like genuinely just know what the signs and symptoms are, what you would do as a nurse, recognizing, perhaps the risk factors. So I think you'll be fine. Any other questions about any of that? I know we're going to be doing test review shortly. Again, I'm available for email questions, and that's it. I'll be here for a few minutes if you have anything else you'd like to ask. And I know the faculty members will be coming on for the test review. You're welcome, Irina. You're welcome, Greg. Thank you.